Hello students, today's class is on urinary tract infections. Urinary tract infections rank second to respiratory infections in their incidence. They are most common among women. Urinary tract as such, starting from the kidney to the proximal urethra, is sterile except the distal urethra. The microflora in the distal urethra are Staphylococcus aureus, Staphylococcus epidermidis, can be non-hemolytic streptococci, diphtheroids, and non-pathogenic Neisseria. Escherichia coli is the most common cause of urinary tract infection, and UTI is a leading cause of gram-negative sepsis in hospitalized patients. Though in general, UTI ranks second to respiratory infections, uh, regarding the hospital-acquired infections, it is the most common. Looking at the definition, urinary tract infection is a disease caused by microbial invasion of the urinary tract from the kidney to the urethra. You can see in this picture, the kidneys and the ureter form the upper urinary tract, and the bladder and the urethra along with the prostate and the males forms the lower urinary tract. What is bacteriuria? It is presence of detectable bacteria in the urine. And pyuria is presence of pus cells in the urine. There are conditions where there is bacteriuria without pyuria, which is seen in diabetes, enteric fever, bacterial endocarditis, in pregnancy, and whenever the urine is contaminated. There is another condition known as sterile pyuria, where there are presence of plenty of pus cells in the urine, but there is lack of growth on culture. The reasons for this is recent administration of antibiotics, gonococcal urethritis, non-specific urethritis caused by chlamydia, trichomonas, and viruses, renal tuberculosis, renal calculi, tumors of the kidney, and catheterization and prostatitis are causes of sterile pyuria. What is urosepsis? It is infection originating from the urinary tract which spreads into the bloodstream, causing life-threatening organ dysfunction. So remember that urosepsis is an infection starting in the urinary tract which enters into the bloodstream, causing organ dysfunction. Let us look into the classification of UTIs. One is based on anatomic site involved. The lower urinary tract infection involves urethritis, cystitis, and prostatitis. Upper urinary tract infection involves pyelonephritis and pyelitis. Based on the source of infection, the UTIs can be community acquired because of improper hygiene, etc. And then hospital acquired, which usually follows instrumentation like use of Foley's catheter, known as catheter associated urinary tract infections, which occurs after the catheter is in place for the past 48 hours. Based on the clinical types, there is uncomplicated UTI, which is infection in a structurally and functionally normal urinary tract. Complicated UTI is an infection in structurally or functionally abnormal urinary tract with or without other comorbidities. So all UTIs in men, in pregnant women, and in children are complicated. This is a very important point to remember. Next term is recurrent urinary tract infection, where there is recurrence of uncomplicated or complicated UTI with a frequency of at least 3 UTIs in a year or 2 UTIs in last 6 months. What are the structural and functional obstructions of urinary tract? We'll see in the subsequent slides. Let us look into the predisposing or risk factors for urinary tract infection. The first one is the age and the gender. In less than 1 year, the incidence of urinary tract infection is equal among the male and the females, and it is mainly due to congenital anomalies of urinary tract which happen in that age. After 1 year, the prevalence of urinary tract infections is more among women. Why is it more among women? Because of shorter urethra and proximity of urethra to the anus. so that whatever periurethral flora, the gastrointestinal flora, vaginal flora present in the periurethral area can easily enter the urethra to cause infection. Looking into the older men, the prostatic hypertrophy is one important risk factor because it causes obstruction of urinary tract leading to infection. Pregnancy is another risk factor because of anatomic and hormonal changes which happen. There is atony of ureter, there's dilatation of the ureter and the pelvis, and there's also the valve which prevents the entry of urine from the bladder to the ureter. There is temporary incompetence in that, causing vesico-ureteric reflux. Looking into structural obstructions of urinary tract, they are urethral stricture, renal or ureteric stones, prostate enlargement, any renal tumors, etc. And functional obstructions of the urinary tract is neurogenic bladder. What is neurogenic bladder? There is loss of control of the bladder in whenever there is trauma either to brain or spinal cord, which is also found in certain neurological diseases like Alzheimer's disease and Parkinson's disease. Is found in multiple sclerosis. The next, metabolic disorders like diabetes are the important risk factor. Instrumentation, that is Foley's catheterization, is an important source of infection. Bacterial virulence, presence of fimbria and adhesins, which aid in attachment to the uroepithelium, which are seen in variety of bacteria like E. coli having P. fimbriae. Then genetic factors, there is familial predisposition, uh, which runs in families where there are receptors on the uroepithelium which which aid in attachment of the bacteria. Looking to the agents which cause urinary tract infection, the most common are the bacterial agents. Usually the parasites and viruses are not common cause, they are not considered as a cause of urinary tract infection except for a couple of them. So looking into the bacterial agents, the most common is Escherichia coli, the uropathogenic Escherichia coli. Others are the Klebsiella pneumoniae, Proteus mirabilis. Now looking to Proteus, it has an enzyme urease which breaks down the urea present in the urine into ammonia. So there's raised pH which causes precipitation of phosphate crystals to form struvite stones. So Proteus is one cause for renal stones. Other agents are Pseudomonas aeruginosa, Acinetobacter, which cause hospital-acquired urinary tract infection, the most common cause of hospital-acquired or catheter-associated urinary tract infections. Other bacteria are Enterobacter, then gram-positive organisms like Staphylococcus saprophyticus. It is one of the most common pathogens in sexually active women, next only to E. coli. Okay, so whenever someone asks you what is the most important cause of UTI in sexually active females, the first cause is Escherichia coli. The next is Staphylococcus saprophyticus. Other causes are Staphylococcus aureus, Staphylococcus epidermidis, Enterococcus, and others like Salmonella, Mycobacterium, Chlamydia. Looking into the fungi, the most common is the Candida albicans, and the infection here is from the bloodstream, that is Candidemia, which is seeding the urinary tract to cause urinary tract infection. This is most commonly considered, the Candida is considered as a pathogen only when there is associated Candidemia, apart from isolating Candida in the urine sample. Looking at the parasites, Cystosoma hematobium and Trichomonas vaginalis are the causes. And the viruses, it's cytomegalovirus, adenovirus, polyoma viruses like JC and BK virus and herpes simplex virus. Cytomegalovirus and BK virus, they are latent in the kidneys. They establish the latency in the kidneys, and on reactivation of the infection, they are shed in the urine. Adenovirus causes hemorrhagic cystitis. Let us look into the pathogenesis of urinary tract infection. First, looking to the modes of transmission, there is ascending route and descending route or hematogenous route. Ascending route is the most common route. That is, this is infection from the enteric endogenous bacteria. That is the flora in the periurethral area. What is the flora in the periurethral area? We've already discussed. It is usually the gastrointestinal flora and vaginal flora. So most commonly it's the gastrointestinal flora like E. coli and Enterococcus and other gram-negative bacilli which enter the urethra to cause infection. Looking to hematogenous or descending route, it's rare and it's usually cause of upper urinary tract infection. The bacterial infection in the blood enters the urinary tract to cause the infections. The organisms commonly associated with this condition are Staphylococcus aureus, Salmonella, Mycobacterium tuberculosis, Leptospira and Candida. So hematogenous or descending route is a rare route where there is a bacteremia with these pathogens which enters the urinary tract to cause the infection. Further looking into the pathogenesis, how does this happen? The periurethral flora, it enters the urethra, colonizes the urethra, further migrates to the bladder. There is colonization and invasion of the bladder, which is mediated by the pili and the edescence. We already know the P. fimbriae of the E. coli, which is followed by neutrophil infiltration. Then there is bacterial multiplication and bacteria tries to evade the host immune response. Some of them form biofilm, so they're protected from the host immune cells. Further, bacteria release certain toxins and proteases which cause epithelial damage. If the infection is not controlled at this point of time, it further ascends to enters via the ureter into the kidneys. It causes colonization of the kidneys. There's a lot of host tissue damage resulting in pyelonephritis and interstitial nephritis, and further this infection in the urinary tract may enter into the bloodstream causing urosepsis. Let us look into the clinical manifestations. There can be asymptomatic bacteriuria where the patient is not suffering from any symptoms, but we can isolate bacteria in the urine. So asymptomatic bacteriuria is isolation of specified quantitative count of bacteria, that is more than or equal to 10 to the power of 5 colony forming units or bacteria per ml of urine is isolated, and this is irrespective of presence of pyuria and in absence of signs and symptoms attributable to urinary tract infection. So I hope it's clear. Here the patient is not having signs and symptoms of UTI, but when you culture the urine, the count will be high, that is more than or equal to 10 to the power of 5 bacteria or colony forming units per ml of urine. Then in lower UTI, there is cystitis and acute urethral syndrome, and upper UTI presents as pyelonephritis. Looking into asymptomatic bacteriuria, in whom is it clinically significant? Asymptomatic bacteriuria is clinically significant in pregnant women and those who are undergoing any prostatic surgery or urological procedures. These are the people who should be screened for asymptomatic bacteriuria and should be treated if found, if the colony count is more than 10 to the power of 5 CFU per ml. In whom is it not significant? In non-pregnant women, premenopausal women, catheterized patient, old age, or patients with spinal injury. What is cystitis? It's infection of the bladder and the symptoms are dysuria, that is pain during micturition, frequency, urgency and suprapubic tenderness. Next is acute urethral syndrome, which is seen in sexually active females where there are symptoms of cystitis, there is pyuria, but the bacterial count is low. It's between 10 to the power of 2 to 10 to the power of 4 colony forming units per ml of urine. In pyelonephritis, there's inflammation of the kidney parenchyma, the calyces, and the renal pelvis. Here, along with the above symptoms, you have systemic manifestations like fever, pain at the at the costovertebral angle, vomiting, fever accompanied with chills, etc. Looking into laboratory diagnosis, what are the specimens collected? The specimens collected can be clean catch midstream urine. Clean catch means the urine sample collected with aseptic precautions, and midstream urine sample is the sample which constitute the middle portion of the urine flow, not the first portion and the last portion, the details of which we'll discuss in the next slide. Suprapubic aspiration from bladder is usually recommended in infants and children who can't pass urine, uh, we, in whom we can't collect midstream urine sample. Okay. In this suprapubic aspiration, if you see in the picture below, uh, you, you puncture into the bladder using needle and syringe after appropriate aseptic precautions at this suprapubic crease. Okay, to collect the urine sample. In catheterized patient, that is from the Foley's catheter, how do you collect? We have to collect from the Foley's catheter, not from the collection bag. And before collecting, you have to clamp the distal portion of the catheter and you have to clean the area with the alcohol wipe and then only collect. In renal tuberculosis, early morning urine sample, the whole urine sample is collected, early morning sample. And in urethritis and prostatitis, the initial flow of urine is preferred. But routinely, the preferred sample is midstream urine sample. And once you collect, it should be immediately sent to the lab within 30 minutes to 1 hour. And if any delay of more than or 4 hours, you have to add boric acid into the sample. And if there is a delay of less than 4 hours, you can refrigerate the sample. Looking into collection of midstream urine sample, in female patients, you ask to spread the labia using plain soap or antiseptic. Yeah, they have to wipe from front to back and dry with tissue. In male patient, he has to retract the prepuce. Using plain soap or antiseptic, he has to clean the glands and dry with the tissues. And now they have to begin passing the urine, stop the flow in midstream and pass several ml into the sterile specimen container without touching the rim of the container, and then stop the flow before it ends, recap the container and pass the remaining urine into the lavatory. So this is the instruction for collection of midstream urine sample. Looking to the laboratory diagnosis, first is you have to do examination of the urine. What is its color? Is it cloudy? Cloudy urine indicates towards the urinary tract infection. Is it red? Usually seen due to hematuria in tuberculosis. Is it brown in color, which indicates intravascular hemolysis? One of the causes black water fever. Is it milky white, which happens in filariasis, Bancroftian filariasis? Next is microscopy. You have to examine the wet mount for the pus cells, for the RBCs, for the yeast, for the trophozoites of Trichomonas vaginalis, and for the eggs of Cystosoma hematobium. So pus cells, if you find more than 10 per high power field in couple of fields, you can take it as significant, and RBC should be more than 3 per high power field to consider as hematuria. Next is the gram stain. If you find even 1 bacteria per oil immersion field in couple of fields, then you can take it as significant. If you're suspecting renal tuberculosis, you have to do Zeal-Nielsen staining on early morning urine sample for at least 2 to 3 consecutive days to find acid-fast bacilli. Then there are some screening tests like leukocyte esterase test and nitrate reduction test. Next is culture, which is a gold standard. Then molecular methods like polymerase chain reaction or the PCR for detection of agents of non-gonococcal urethritis like chlamydia, etc. Viruses, so on. So this is a microscopy wet mount showing the yeast cells, the oval budding yeast cells. And then the picture below you can see the WBCs which have granules in the center. Then you see the RBCs, which are smaller in size than WBCs, which have definitive outer margin and which have no granules. We can also find Cystosoma hematobium eggs in the urine, and even the trophozoites of Trichomonas vaginalis in the females. This is a gram stain picture showing gram-negative bacilli. And if it's gonococcal urethritis, you also find gram-negative intracellular diplococci, which are kidney-shaped in the gram stain. Looking to screening tests, they are done by urinary dipstick assay. They test for presence of nitrates in the urine, leukocyte esterase, proteins. They test the urine pH, etc. Looking into test for presence of nitrates, the test strip is impregnated with nitrates, and when you dip it into the urine, the coliform bacteria, if they're present in the urine sample, they have nitrate reductase, which convert the nitrates into nitrites, and there's change in the color of the reagent impregnated area, which should be compared to look for whether it's positive or negative, using the color label on the strip box. Similarly, detection of leukocyte esterase, which is an enzyme released from pus cells, and pH to look for whether it's acidic or alkaline. Alkaline pH indicates towards the stones in the kidney, which is usually caused by Proteus. So these are rapid bedside tests, but they are less sensitive. What do you mean by less sensitive? The false negatives might be more. Looking to culture, the media used are blood agar and McConkey agar, or CLED. What is CLED agar? Cysteine lactose electrolyte deficient agar. You do a semi-quantitative or quantitative culture. You know that quantitative culture is a pour plate method, and then you have to incubate the plate for 18 to 24 hours at 37 degrees centigrade. You can see the CLED agar plate. If they're lactose fermenting bacteria, they appear yellow on CLED agar. Whereas on McConkey, the lactose fermenting bacteria appear pink in color. Looking to semi-quantitative culture, we're not learning more about quantitative culture, it's pour plate method, but we have to know about semi-quantitative culture, which is done in most of the laboratories. We use a standard loop method, wherein a sterile calibrated loop, which carries about 1 microliter of urine, which has a capacity to carry 1 microliter of urine, is dipped into the urine, and then the culture media plate is inoculated. How is it inoculated? Look into the picture. The primary streak is made as a straight line across the plate, and then the secondary streak is made in a zigzag pattern, and this plate is incubated at 37 degrees centigrade for 24 hours. The next day you have to count for number of colonies. And how do you get the total number of colonies? Is number of colonies which are on the plate into 1000. Why 1000? Because 1 microliter loop, for 1 microliter loop, 1 colony represents 10 to the power of 3 bacteria or 10 to the power of 3 colony forming units per ml of urine sample. Okay. Looking to interpretation of this colony count, if this colony count is more than 10 to the power of 5 colony forming units per ml, it is known as significant bacteriuria. So this is known as CAS concept. It was CAS who has investigated the midstream urine samples, who found that midstream urine samples of 95% hospitalized patients suffering from pyelonephritis, they showed the colony count of more than 10 to the power of 5 CFU per ml. Okay, and this is with respect to midstream urine sample, and this is with respect to gram negative bacteria like E. coli, Klebsiella, Proteus, Pseudomonas, but not gram positive bacteria. If the colony count is between 10 to the power of 4 or 10 to the power of 5 CFU per ml, this bacteriuria is of doubtful significance. That is, you have to correlate with the clinical signs and symptoms. If the colony count is less than 10 to the power of 4 CFU per ml, it is considered as insignificant bacteriuria, but here also exceptions exist. If it's suprapubic aspirate sample or a sample obtained by cystoscopy, even this count is significant. But if it's midstream urine sample, it is insignificant. And now let us look into where the CAS concept is not applicable. Catheterized sample, if there is any urinary obstruction, in descending infections, in infections with gram-positive bacteria, in acute urethral syndrome, and wherever there is recent use of antibiotics or diuretics, the CAS concept is not applicable. Let us again look into the quantitative criteria for UTI. So in asymptomatic individuals, what is a significant colony count? It should be more than or equal to 10 to the power of 5 colony forming units per ml of urine sample. So in IDSA, which is Infectious Disease Society of America, recommends that 2 urine samples in females should show this count. In catheterized patient, even count of 10 to the power of 2 CFU per ml is significant. And in suprapubic aspirate or intraoperatively obtained sample, any growth is significant. Further, let us look into other culture methods which are not routinely performed. One is dip slide culture, where a plastic slide coated with a cled on one side, cled media on one side, and McConkey on the other side is dipped into the urine sample and incubated at 37 degrees centigrade, and next day the colonies are counted. And a filter paper strip method, where a filter paper you can see onto the right hand side, 6.3 meters in length, is dipped into the urine sample and it is impressed on the culture media. Next day, after incubation 37 degrees centigrade for 18 to 24 hours, next day you count the number of colonies, and you can, using this table, if there are around more than 25 colonies, then only it is more than 10 to the power of 5 CFU per ml of urine. The next, let us look into antibiotic sensitivity testing. The indications are significant bacteriuria, recurrent UTI, and complicated UTI are the indications to perform antibiotic sensitivity testing. What are the antibiotics used? In treatment, nitrofurantoin, phosphomycin, cotrimoxazole are used in acute cystitis cases. And if this cystitis is complicated, drugs like ertapenem and amikacin are used. In pyelonephritis, usually the agents are antibiotic resistant, so the antibiotics preferred are piperacillin, tazobactam, ertapenem, amikacin, etc. In conditions like epididymoorchitis, we also use quinolones and doxycyclines. Usually the use of quinolones should be restricted. They should not be used, or they should be only used when indicated. Even first and second generation cephalosporins are commonly used for uncomplicated conditions. So this is a urine culture report. How the report is given. Urine is cultured. It's an aerobic culture, and in the direct smear, in the gram stain, we look for what are the bacteria present, and even we can identify the pus cells. Then we give the colony count. Here you can see it is 80,000 CFU per ml, which is it could be probable significant bacteria. The clinician has to correlate with the signs and symptoms. And the isolate was E. coli, and these are the list of drugs which were kept for sensitivity, showing the sensitivity report. Thank you.